So first of all, I want to thank Dr. Sagupta for standing here with me. It's like me playing basketball with LeBron James. It's kind of the same analogy. It's a true privilege to be with him here and allow me to have this debate with really no very deep knowledge on this subject. So we debated last year, and it's obviously more and more difficult to refute his arguments, mainly because of the amount of growth that artificial intelligence is having. I mean, if you look at the new algorithm, is every day, all the big companies are coming with new ways to do things faster. Now, going back, probably the title of this debate should be, we're not going to do echo anymore. He just showed that from an EKG, he knows the color of the eyes of the patients, he knows the strain, if the patient has SAM, I mean, everything. So probably at the end of the day, we're not going to be reading echoes. Everything is going to be contained on an EKG. So I think the future is not great. So last time from our last debate, one of the arguments is the technology, although advanced very fast, is still a little bit crude. And in order to apply that in large clinical settings, we still need to have more accurate and reproducible and be transparent. Transparency is something that is lacking in all these technologies, and I think even the big companies struggle to know how the hell these AI algorithms are coming with all this information, which is important if they make mistakes. Dr. Sengupta also showed that, and I think we're concentrated today, the discussion in this pie here, is the technology mature enough to interpret an echo in totality and give us an accurate report or not. I think there are attempts in all these steps, but I think today we're concentrating in this particular area. So what are the arguments to have that in echo? Well, and this is probably true, that reduces dependency and variability. It doesn't say anything about accuracy. It could be wrong all the time, but it's going to be wrong all the time in the same way. But there are many errors, as you can see here, no? Is from the technical standpoint in the coding of that, and also how do you limit confounders and other variabilities that come with the hundreds or thousands of parameters. And also, I'll talk about other limitations in other. So this is very, very good, no? So now some papers when these machines will come with an echo, but this is already several years old. And in which lab now we have a computer that reads the echo in totality? Nobody. So nobody. 7 years later, we're still reading the echoes almost identically that we used before. So it's taking a longer time, but I think that these people thought that was going to happen. And because what we're talking about, that the machine is going to automatically identify the views and segment that, is going to measure everything, not only what we see, but what we don't see according to the latest information. It's going to identify what is abnormal. It's going to analyze, put everything together, and it's going to write something. So I think there are some advances in ejection fraction and segmentation, but I was still far away from these other applications of that. And this is what we have currently. Pretty pictures that are very reproducible, but often very inaccurate. So it still requires a lot of tweaking these things to get us the information that we need in clinical practice. Also, a strain is probably, I mean, all the machines now produce automatically and probably with some degree of reliability, although the tracking remains something that needs to be adjusted manually and physically. And this technology, which is this GPS, which I don't know who's using that, but the hope is not for us. This is for centers when people had no idea how to do an echocardiogram, or the patient now using their own hands and send us this information that I guarantee is going to be probably poor quality. There are several systems. The major vendors already had, Philips and GE and Siemens has AI incorporated that with different degrees of success. And other companies obviously are trying to produce reports from the measurements. And this is, I think, from one of the companies, I think Dr. Sagupta is familiar with. And it's coming not with the analysis, but more of the prognostication of the severity of lesions of these patients. Again, we have to see what happens if you apply to the large population. This is the latest, and I think I found this very interesting. I think this is from several academic places. I think the coding, if I'm correct, is public, so it could be implemented. But what they are proposing is to create full report from the data. And if you go to their webpage, they are very accurate in severity of aortic stenosis, mitral regurgitation, aortic insufficiency. All the things are 93% accurate. However, from their page, look at this. The aortic valve is normal, no aortic stenosis, nothing. But the peak velocity is 2.5 meters per second. So this is obviously abnormal. And even in their own page, they put this number with no comments. This patient, for some reason, maybe has SAM or who knows what this patient has a gradient of 25 millimeters of mercury through the aortic valve. And in their own report that is for cell, this is not mentioned at all. So it's still a limitation that even with these highly sophisticated programs, still come through. So I think today, what is doing the AI is estimation of ejection fraction and strain. I agree that is something that is done, again, with variable results, maybe some basic ejection measurements, and guidance for novice users that, again, doesn't pertain to us because we have experienced sonographers. And it may be important, again, for wider use is identifying pathology with a single image, severe aortic stenosis, maybe amyloidosis, maybe hypertrophic cardiomyopathy. So for single entities, they are developing this algorithm that may identify, but doesn't apply really to us. This is if someone is going to screen with a portable machine in large populations, but not for clinical practice. And I'm not the only one saying that. This is a recent publication from Japan, already achieved only two things: ejection fraction and some guidance, again, that nobody used that. And then the potential, if you use all the data, to do something that Dr. Sengupta mentioned, that may be improving the workflow and making our life a little bit easier. That remains to be seen. Now, when you debate an expert, the good thing is that you can find your argument against him in all publications. So this is actually a great paper that he published in Lancet, and I recommend everybody to listen. But in that, he actually lists these are not a small problem. These are huge problems that this technology is still facing, and there is probably no easy solution for one of them. For some reason, one of the major problems that is hallucinations or reverse hallucinations is it has dropped from the radar. People are not mentioned that, although remains a significant problem when the machines either fabricates information or doesn't portray information that should be shown. In terms of the evaluation of that, and this is a quotation from, I think, the former FDA commissioner, I don't believe there is a single health system in the United States that is capable of validating an AI algorithm that is put into place in clinical care. So what it means is we're going to pay a company for putting an algorithm in place for us, and we have no idea if the thing is going to work or not. Not only that, there is no system that has the capability to do that. So this is a lot of faith that the data that was acquired somewhere else can be applied to your institution with similar results. And the other thing is all this system requires a lot of people to check them out if they are true or false. This is another list. I'm not going to go through that again. For another center, the list is endless of important limitations for the application for that. When Dr. Sengupta showed that yesterday about this strain base or extract from EKG, my jaw really dropped to the floor. My God, what are they getting this information? Well, I mean, if you go the line, it's actually not bad and blah, blah, blah. But look at the spread of data. So if you want to apply that to your patient, to your family, to yourself, you don't know where the hell are you. If you do 1 million patients, yes, the ROA is going to be spectacular. But this is still within the variability of the text. And finally, cost. Who's going to pay for that? Every year, as someone was mentioning to me, every echo is reimbursed less and less and less. And the companies are going to pay per echo, $10, $15, $20. And Sengupta again mentioned very intelligently, despite of the growth, there is no evidence that it's going to be cheaper, faster, more accurate, no evidence of nothing. It just looks great. No? So in conclusion, I think AI is unavoidable. I mean, he showed the progress, and I believe in that. We start use fragments of that, and ejection fraction, strain maybe, and maybe use on a population level to identify once in a while an amyloid and once in a while a hypertrophic cardiomyopathy. But I think for us in this room, we're going to be reading echocardiograph in the old way for the foreseeable future. Thank you.